Welcome to our total joints replacements class. My name is Clarissa. I'm a nurse navigator with the OHSU orthopedic team.
Hi, everyone. My name is Dylan Mangrum. I'm a physician associate working with our total joints team.
And we're going to be presenting the total joint class for you today. Our goal here is to educate you and your loved ones before your surgery, and we want to be able to make this as comfortable for you as possible. We hope this is a helpful experience for you to help plan for before surgery, your stay in the hospital, and your post-surgery recovery as well.
So first we'll talk about hip replacement. Many of you will be getting ready for this type of surgery, and this slide demonstrates the parts we're talking about with the thigh bone, the pelvis. So the letters correspond to different parts that we'll be working with. The top of the thigh bone, the letter A, the actual joint where letter C is, where the top of the thigh bone is resting inside the socket part of the pelvis, which has the letter B. And the cartilage is what we're actually treating here. Is the cartilage is worn out in arthritis, so we're replacing the damaged area, basically focusing on the part where the letter C is located. And we'll remove that part, we'll replace it with artificial components. So that's what a hip replacement means. We're recreating the ball and socket type of joint with metal and plastic and ceramic parts that restores the hip joint to normal function and eliminates pain. And then knee replacement is similar, resurfacing parts of the bone that are damaged. And the letters here correspond with the thigh bone and shin bone and the kneecap, as you can see labeled there. Also, again, these joint areas are lined with cartilage, so we're replacing the damaged area where the cartilage is worn out and the bones right underneath that. So in the knee replacement, we're resurfacing the end of the thigh bone, the shin bone, and sometimes the kneecap, depending on if it's damaged or not.
So we want to introduce you to your team. You're going to meet a lot of people in this experience, and a lot of us go by different abbreviations that can be really confusing as well. So first, you're going to have your surgeon. We work with 4 different surgeons here at OHSU: Dr. Huff, Dr. Schabel, Dr. Kagan, and Dr. Schwantes. Your orthopedic surgeons are doctors who have gone through many years of orthopedic training. They help fix bones, joints, and muscles. And then they have additional surgical training for joint replacements. You'll also have a team of physician associates. You'll also hear them referred to as PAs oftenly. You have Nate, Dylan, Jill, Patrick, and JC. Your PAs, they work closely with you and your surgeons. They'll be in your operating room with you in your appointments as well. You might frequently see them rounding on you in the hospital after surgery as well, but they can perform exams, diagnostic tests, and order any medications and therapy. So you will see them as well. You might also have resident physicians and fellow physicians during your experience. Resident physicians are part of OHSU's orthopedic surgery training program. They have graduated medical school, so they're doctors with several years of experience, and they work closely with your surgeons. And then your fellow physicians, they've completed their residency program and are now focusing on orthopedics. So you might have one or both of those with your provider. Both residents and fellows, they'll be providing medical care alongside your surgeon while they're developing their skills as well. There's also nurse practitioners. Roy, he works specifically with patients at the CHH location, so you might see him rounding on you after surgery. Nurse practitioners are advanced practice registered nurses that have completed a master's or a doctoral program. They work closely with your doctors while you're in the hospital, and they can also order tests, prescribe meds, and manage your care and discharge. You will also either have an appointment with a nurse navigator or a case manager. Your nurse navigators, they have specific orthopedic knowledge that will be helpful for you in this process. They help just be a resource during your pre-op and post-op experience. They can answer a lot of questions for you during your experience as well. Case management, they're also registered nurses that help prepare for more complex discharges. They can answer a lot of questions about insurance, complex discharge needs, and any equipment you might need after surgery.
All right, so we like to get everybody ready for surgery. This involves a lot of different things that really help get people optimized, as we like to call it. So we especially like to focus on exercise preoperatively. People staying active do better with recovery. So physical therapy is often prescribed preoperatively. We call prehab. You want to get as strong as you can be in preparation for surgery. Keeping your weight down is also helpful. So this can be a part of physical therapy and diet. We often do send people to our bariatric department for that purpose as well, not for bariatric surgery necessarily, but for their non-operative treatment program, which quite often is very helpful. And then diet is important. Focusing on protein intake helps people build muscle and is just generally good health advice, along with a well-balanced diet and avoiding too much sugar or carbohydrates. And then managing other stressful situations like work and other issues is very helpful just to give your body an ease in recovery and not overloading it with other things if you can at all avoid it. Seeing your primary care doctor is always helpful just for general health maintenance. This always helps us if people are in more optimal shape and have not had other issues that might delay their surgery. And as you see there, there's some things mentioned like blood sugar, blood pressure, and making sure you take your medication so you're managing medical problems. That helps you stay optimized for a surgery as well. And then some logistics are getting to and from the hospital. This is something care managers and nurse navigators also talk about. We like to know who's helping you before and or after surgery, and especially that somebody's available to help you out afterwards with some basics. Making sure you're ready at home is that you have hazards removed like rugs and cords that might be in the way. You have plenty of food around. If you have pets, making sure they're either cared for outside the home by somebody you trust or boarded, or just able to manage them inside the house where they won't trip you up, which can be a danger for some people after surgery. And then equipment you need, we tend to arrange for that if you don't have it, like a walker and a cane. And our preoperative medical clinic is what the PMC there says in the last line. They give patients the timeline for when they need to stop medications or what they can continue up until the surgery. They give this list to you in paperwork and MyChart, so that appointment is one of your preoperative appointments to get ready for surgery.
So, like Dylan was saying, there's a few appointments you're going to have before surgery if you haven't already had them. The first is your pre-op appointment with your surgery team. So that will either be with the surgeon or the PA. The perioperative medicine clinic, also referred to as PMC. They do a lot of the testing, making sure you have the green light from a medical perspective. Physical therapy, the majority of our patients will see physical therapy at least once before surgery, and then either an appointment with a nurse navigator or a case manager.
Focusing on tobacco and nicotine, these go hand in hand. So obviously tobacco has nicotine, but there are nicotine replacement products quite often used so people can stop smoking. We actually want people off of any tobacco and nicotine replacement because they are a risk for surgery. So complications, including infections, blood clots, and heart problems are related to those products. We want people off all of that, and we do screen for it if people are smoking or using any sort of products. We do a screening process, so you need to be free of nicotine for at least 4 to 6 weeks prior to surgery. And if we retest and find that test to be positive, we have to delay the surgery due to the risk associated with being on that. So good things to remember. We often are going to cover that in clinic when we're seeing somebody and trying to plan for surgery as well. And MRSA is a staph bacteria that's resistant to some antibiotics. So we test this. It's actually carried in a decent number of people. So this is a nasal swab to screen if you happen to carry that bacteria. It's not a disease in and of itself, but if you carry a resistant strain of that, we want to find out before surgery, and then usually we'll put you on an antibiotic that eliminates that bacteria. So this is helpful in case somebody is to get an infection with that later, that they don't have a resistant bacteria, which is much harder to treat. We also give antibacterial wipes prior to surgery. This is actually to be used close to the surgery. You would get instructions on that with the preoperative medical clinic also.
The night before and the day of surgery, only take the medications advised at your PMC appointment. If you forget what you guys talked about, you should have been given an after visit summary from that appointment as well in your MyChart. So always refresh on that. Do not eat anything after midnight, but it is okay to have water up until an hour before you need to get to the hospital. So it's important to stay hydrated leading to surgery, and then complete your chlorhexidine wipes or HIPAA baths as directed. After surgery, time after a total joint replacement has significantly changed. Hospital stays vary by the patient. Some will discharge the same day, while others might need one night. It is very rare to have to go to a skilled nursing facility or stay multiple nights after a total joint surgery. So if that does happen, they typically is not determined until after the surgery. Your hospital stay, these are just some photos of what PACU, which is the recovery unit, a med-surg unit, in a room look like, just so you kind of can gauge, if you haven't been in the hospital for, what your surroundings might be. While you're in the hospital after surgery, you're going to be taken to PACU, which is the post-anesthesia care unit, for monitoring while you wake up from anesthesia. They're going to monitor your vital signs, which are taken pretty frequently right after surgery. So they take them every 15 minutes, then every 30, every hour, and then every 4 hours. They're going to be monitoring your pain while you're in the PACU because you're still pretty groggy. They'll be giving you typically IV pain medication. Once you're awake and stable, you'll be transferred to the surgical unit, which looks a little bit different depending on which facility you are having surgery at. So you can have surgery at the Venice location, up on the hill, or the waterfront, which all has their own recovery units. Once you are taken to your room, we'll continue monitoring those vital signs. If you stay overnight, just know staff is going to wake you every 4 hours to do vital signs and assessments. The goal is to transition you to oral pain medications because we can't send you home with an IV, so we can't do IV medications at home. So typically we'll do Tylenol, NSAIDs like ibuprofen or naproxen, and oxycodone. We try to do multiple pain medications because it helps manage pain a little bit better. And then typically the goal is to discharge around lunchtime or noon, depending on if you meet your milestones. The milestones you'll have to meet before discharging is you have to be able to ambulate safely with physical therapy and staff. We don't want to send you home if you're unsteady or unsafe. So while you're in the hospital, staff has to be with you every single time that you get up out of the bed. If they're concerned about your safety or you're getting up frequently without asking for assistance, they might put a bed alarm on your bed just to notify staff that you're up. And that really is for your safety. It's not uncommon to get dizzy when standing after surgeries. Some of these surgeries also have nerve blocks, which can cause unexpected weakness. So we always want somebody assisting you. We need you to be able to void independently. Anesthesia can cause urinary retentions, and sometimes that just takes time to resolve. Other things like drinking, caffeine, and walking can help as well. They can use an ultrasound to monitor how much urine you're retaining in your bladder. And then you also have to be able to tolerate food without nausea. So start really slow, eat things that are simple, such as soup, mashed potatoes, applesauce, and then go from there. And then, like I stated earlier, we do have to have your pain controlled with oral medications. Common prescriptions at discharge, we typically will give Tylenol and anti-inflammatories unless these are contraindicated for you specifically. We'll also give aspirin typically because you're a higher risk for blood clot. So just a baby 81 milligram aspirin twice a day. If you're somebody that's already on an anticoagulant before surgery, you'll resume that afterwards, and your surgeon will help prescribe that for you. Stool softeners, it's really easy to get constipated after surgery from anesthesia and narcotics. So we'll order those for you as well. Narcotics, typically we prescribe oxycodone. If you're somebody that can't take oxycodone or you know it doesn't work for you, make sure to let your provider know, and there's alternative medications we can prescribe. Narcan, you've probably have heard of it. It's typically always ordered anytime a narcotic is ordered, and it's just for accidental overdoses. It's a nasal spray, so you might see that in your pickup, but it is optional. Some patients with a high risk for infection might be prescribed an antibiotic like Keflex. And then DME, which is like a walker, shower chair, cane, those things. Hopefully, we can get prescribed to you before you go into the hospital. But if you don't have one of these and you need one, make sure you let us know before you discharge and we can order it as well. And then we highly recommend that you pick up your prescriptions or equipment at your surgery location. We can typically fill those inside those pharmacies and have you pick them up before you leave.
All right, so we'll talk about the dressings and lines and drains as you see there. So the nerve block is something anesthesia will talk to you about. If you're getting a knee replacement, we can offer this option, and they discuss that with you in the preparation for surgery on the day that you're actually there for surgery. There are some dressing types we apply: the Prevena, the Pico, and the silver foam dressing. These are wound vacuum type of systems. Not everybody needs one of these. We tend to use this if we think there's some risk of bleeding or maybe some difficulty in healing. Most people actually get the silver foam dressing, which, as it says, is antimicrobial. It does have some silver content in the bandage portion, so it's kind of a gray appearance. And this is what most people are going to get. And that's kind of determined at the time of surgery based on what the surgeon sees.
Post-operative swelling and inflammation, it's super common to swell and bruise after surgery. I would say that's probably the number one call we get from patients. So just it is expected and typically normal. So, and it also typically resolves about 1 to 2 weeks after surgery. So things you can do is icing, elevating, that can help decrease the swelling in both your hips and knees. And then if you're somebody that can take anti-inflammatories, we'll typically prescribe you either ibuprofen or naproxen to help with the pain and inflammation as well. Drainage, bleeding, swelling. So bleeding also can happen after surgery. If bleeding is increasingly significant or you feel like the dressing is losing its seal because blood is leaking from it, send us a photo in MyChart or give us a call and we'll help guide you on what to do. Depending on the amount, interventions typically include just monitoring it. We might have you change the dressing out. And typically just resting, icing, compressing, and elevating. Typically, the bleeding will resolve after 1 to 2 days.
So infection's always a risk with surgery, and you will have some increase in how your immune system works. It typically results in a low-grade fever. So as it says there, 100.4 is when we start getting a little bit more concerned about a fever actually being a sign of an infection. So keeping in mind your temperature will go up a little bit. We often will ask people to take Tylenol, but we do want to know about this. If it's occurring, chills, it would be a sign of maybe the infection progressing. If you're getting a lot of swelling, and especially have redness around the incision area, and especially if there's a lot of drainage happening. These are things we need to know about so we can decide, do you need to come in? Do we need to change anything about the treatment? And then especially if the wound is opening up. This is also really rare to happen, but it's something we need to know about if it's occurring. So you call us or send us a MyChart message, and then we decide what to do from there.
Total joint precautions. This means there might be some limits to certain hip or knee movements after surgery. So, knees, we don't want you placing a pillow under your knee. Keep the knee elevated and fully straight when you're at rest. So, if you think you're going to be sitting for a few hours, try to keep it in the straight position. You should be sent home with one of these blue wedges from the hospital. They're not perfect. They still put a little bend in your knee, so you might need to roll up a rag or a pillow and put it under your heel area. And then hips, depending on your approach, you might have some precautions for 4 to 6 weeks after surgery. And if you are one of those approaches, we'll go through that with you before surgery and we'll go through with it after surgery as well.
The blood clots typically have about a 1% chance of occurring with this kind of surgery, both hip and knee replacement. We mainly prevent these by getting people moving. So early mobilization, very important. We want people walking. The day of surgery, the physical therapist or nurse is usually helping you get up and move. Anticoagulation for 6 weeks is typical. Most people will go on aspirin. We do have some other blood thinner choices. And if somebody happens to already be on a blood thinning medicine, then we are just typically going to resume that the day after surgery. It does depend on what you're on as to when you have to stop the anticoagulant prior to surgery. This is usually determined by your primary care doc or cardiologist or the typical doctors involved with those kind of decisions. The sequential compression device is just used in the hospital. We do put compression socks on in the operating room typically, and then the SCDs go on top of those, and then you just use it at the hospital. You don't have to have that at home, but the compression socks do continue at home. Typically, we're recommending those for about 6 weeks. The signs of a DVT or blood clot is pain that doesn't improve when you elevate your leg, calf pain and swelling or redness, and a lot of people describe it as a spasm or a cramp that just doesn't let up. I always advise people, let us know if you're having those symptoms. We can order an ultrasound to look for that. And we typically try to do that through our office, arranging the ultrasound rather than sending you to an emergency department. That is an option. If somebody needs to go to an emergency department, especially on a weekend when our office is not open or at night, then by all means, we want patients to check into that and address it as soon as they can. But always let us know if these things are occurring. And then a PE is a pulmonary embolus. That's where the blood clot actually makes it into the lungs, although the clot does form in the calf, but it can travel in the veins and land in the lungs where it would cause symptoms like shortness of breath, chest pain, anxiety, regular heartbeat, or people feeling dizzy or lightheaded, even coughing. And if you're having these kind of symptoms, especially the shortness of breath, chest pain type of things, that's the kind of thing you need to go to the emergency department for. We can't really do an ultrasound to check for that. It requires more advanced testing. And chest pain and shortness of breath can be symptoms of other issues, potentially heart problems. So that's why we ask people, if you're having those kind of issues, go directly to the emergency department. And pain control, we're sending people home with pain meds. We mentioned those earlier, opiates, anti-inflammatory meds, Tylenol, and we do have non-medication type things we recommend. Icing, the ice device that we give people in the hospital. Elevation is helpful. We mentioned the nerve block earlier. That's something that you potentially can take home, and it usually works for a few days before you remove it. And then keeping ahead of pain meds at the start of this process. After being discharged, you only have the oral medications, so you want to keep control of pain pretty closely at the beginning. And then tapering off, which we mentioned, can occur later as the pain is diminishing. Radiating pain to the thigh is pretty common with both hip and knee surgery. So it's important to know if you have a hip replacement, you'll quite often have pain radiating to the thigh and even to the knee. This typically resolves with time, but it does take a few weeks. And over-the-counter meds, mentioning there Tylenol and ibuprofen and naproxen. Some of these will be based on whether or not you can take them, especially the anti-inflammatory types like ibuprofen and naproxen. And then refills, we want patients to contact us, either call or my chart message suffices. We can electronically send prescriptions to any pharmacy that you wish. We do like 72 hours notice, and this can be a factor when we get close to the weekends because pain medications cannot be refilled over the weekend. So the sooner you can predict maybe running out of meds, the sooner we can get a refill sent and avoid the situation of running out.
Constipation is common after surgery due to anesthesia and pain medicine, so it might take a couple days to have a bowel movement again. Ways to prevent constipation: we're going to send you home with some prescriptions for bowel care, especially while you're taking the narcotics. These are typically Synacot and Miralax. There's also more aggressive over-the-counter options like suppositories, enemas, and Magcitrate if you're having constipation lasting longer than a few days and Senna Miralax aren't working. It's important to stay active, hydrate, drink lots of water, and eat a high fiber diet.
Physical therapy is going to be really key, especially in knee replacements. So we'll start with that. The physical therapy is typically arranged even before your surgery. We have this discussion in our preoperative appointments. Either myself, the PAs you see, the doctors you see, or the care managers, nurse navigators will often discuss this. We like to get therapy ordered and arranged. It's typically twice a week for about 6 weeks, and getting the visits booked as soon as you can is really helpful so that we don't miss out on those. And for knee replacements, we especially want people to wait about 7 days to start with a physical therapist because you don't want to push too hard initially. You're doing some things on your own, and the therapy will get a little bit more intense at the visit when you see the therapist at 7 days. Additionally, physical therapists especially like if you're pre-medicating before you show up because they do have to push on your leg a bit to get it mobilized and break up scar tissue in the knee. So having good pain control is really helpful for doing PT sessions where you might expect to get more pain. Hip replacements, we don't typically do a lot of formal therapy, at least in the first 6 weeks, because we're allowing for some time to heal. And the exercises are pretty basic. It's walking and doing some body weight exercises, which we cover preoperatively. And then once you reach the 6 week mark, typically we're also seeing in the clinic at around 6 weeks. So we can order therapy and release patients to do whatever they feel comfortable doing, including going to physical therapy that's a bit more intensive. So when I say that, it typically means strength training, like resistance type of training. That means weights or bands, or maybe more impact type stuff, a little bit more impactful. That is like bicycling, swimming, and other things can be added in at that point. Dental procedures, we have recommended in the past that people take antibiotics. We've actually moved away from that in recent months. So we do recommend avoiding any routine work for 3 months after the surgery. This helps reduce risk of getting infections and joint replacements. However, routine dental antibiotics prior to things like cleanings are no longer recommended. Sometimes we will have people use that if they have a situation of a prior infected joint replacement or immune system issues where we feel like they're just going to need to be more cautious with procedures. So the key thing here is don't do anything like cleaning or routine stuff for at least 3 months after your surgery. But if anything urgent comes up and you need to get it treated, then by all means, let your dentist know you've had this surgery and also let us know so we can work on arranging antibiotics pre-procedure.
Patient IQ, you're going to be enrolled in Patient IQ once surgery is scheduled. It's a patient engagement platform that helps improve communication and patient experience. It also allows us to measure patient outcomes required for centers for Medicare and Medicaid services. So there's options on there that will help. You can check boxes as the process goes. and we'll get notified of those answers. So, for example, if you don't have physical therapy set up yet, you can check that and it will notify us to reach out to you to help assist you get that scheduled. Some of you will get a survey on patient IQ after surgery, and it's really important you fill that out right away. That's actually for Centers for Medicare and Medicaid Services. So keep an eye on patient IQ once you go home from the hospital. After surgery, you're going to get a phone call from a nurse navigator once you are home, typically 24 to 48 hours after discharge. You'll also have a post-op appointment at 2 weeks and 6 weeks to check on your incision and recovery. The Total Joint Orthopedic Clinic is open Monday through Friday, 8 to 4:30. We have the phone number listed for you. We also have after hours numbers, also listed in blue there, and ask to page the ortho resident on call. You're also always available to send a MyChart message. Just do give us a couple days to potentially respond to those.
So this is a list of questions we get quite often. Helpful to know a lot of these details, like when can I drive? That's especially important for a lot of people who don't have a lot of help. Our focus is really to make sure people are safe driving. So we always recommend not being on opiates while driving. It's not that you have to be completely off of opiates, it's just while driving. So if somebody were to drive somewhere and then come home and be home for the rest of the day, they can take their opiates then, or at night, but not in the morning if they're going to go somewhere. So strategizing when you drive can be important. And the other factor is just that you can feel comfortable with yourself driving. So reaction time, this tends to average about 3 to 4 weeks for a lot of people. Your results might be a little different. You might feel like you can drive sooner. And going back to work does depend on what you do. So people who work in construction or landscaping or heavy lifting are usually going to need to take 8 to 12 weeks off. People that are on their feet consistently throughout the day might also need somewhere around 6 to 8 or even 12 weeks. If you work at a desk or work from home, you can often do some of that after 2 or 3 weeks. Although, especially for knee replacement patients, I really explain it's good to think of the recovery as your full-time job because it's very intensive with therapy and activity and elevating your legs. So, at the bare minimum, I would say in an ideal world, don't go back to work for 6 weeks, which would really be good for anybody if they can do that. Showering is allowed immediately. The bandage we use is sealed, so you can shower as soon as you get home, and the bandage can be removed typically between 7 to 14 days after the surgery, and showering can continue even with the bandage removed. We don't need to have you cover it unless we give you any different instructions. That's kind of rare, but if there's any concern we have with that, we would let you know. Stairs are actually allowed immediately, but it is also based on when you feel comfortable. So a lot of patients will maybe sleep on the ground floor for a few days or a week if they can arrange for a hospital bed. Sometimes that's used. Mostly, we'll tend to use a spare bedroom or a couch even. But stairs are navigating, patients can navigate stairs anytime they feel comfortable. Usually they're just minimizing the trips up and down the stairs. Bandage instructions will be given to you when you go home. I mentioned 7 to 14 days is typical as to when the patient can remove that themselves at home, unless we give you any different instructions based on the surgery that we've done. Joint replacements are typically considered painful. It's hard to quantify exactly. Everybody has a little bit different response to pain, but knee replacements we do tend to say are fairly painful, and the medications we mentioned tend to be needed a bit longer in that type of surgery, and as well with physical therapy required to recover from a knee replacement. The implants are made of metal, typically titanium gets implanted in the bone. Both hip and knee replacements have some different options with the metal, but typically it's an alloy of different metals like zirconium, cobalt, chromium, and we also have ceramic parts that we often use in hip replacement. And then there's also a plastic liner typically in hip and knee replacement both.
That is it for our total joints class. We hope this was really educational for you, and feel free to watch this as many times as you need or pass it along to your loved ones or your support team if you feel like it'll be beneficial for them as well. If you do have any additional questions, you can always reach out to us, give us a call, send in a MyChart message, or bring them to your pre-op appointments as well.